Let's talk about the difference in restorations from a simple filling, which is usually a composite material. In the past, it might have been an amalgam material, which had metal filling, which had mercury in it. So we're comparing really a composite plastic filling to an onlay or a crown. Correct? Those are pretty much the three
Inlay,
restorations.
onlay, crown.
A composite, inlay, onlay, crown.
Yeah.
So composite fillings are a one-visit procedure. Usually used on smaller restorations, right? A little area of decay in between the teeth. On the biting surface of the tooth or in between the teeth, a smaller restoration. These fillings are used because they're less expensive. They can be done in one procedure. However, if it's a larger restoration, you want to move more to a substantial restoration, whether it be an inlay, an onlay, or a crown, which is made in a ceramic material.
Used to be something else, right?
Used to be in gold. Yeah. There's different types of ceramic, lithium disilicate, brand name Emax, zirconia, which is kind of like a white metal, is also used in our restorations. So you want to dive into why why a composite restoration would fail and why we decided to move?
Some of the feedback we got from our last talk, when people were asking, said one of the questions was about the filling size, and we've had in our practice a handful of patients who'll have a larger cavity or a larger break in the tooth, and they'll want to do like a filling because they think that it's better than a crown because they've heard things about crowns. So what's your thought process when there's a large void in the tooth that we need to restore, and the solution could be a composite, because logistically you can put a composite in anything. You and I could sculpt
you could
a
do
composite.
A large filling.
I could make it a whole tooth a composite if we had to.
It'll look beautiful when they leave the office.
Right.
And
but we don't do that.
No.
But we recommend against that.
Well, we'll see patients that come in on recall that have large occlusal fillings that take up almost the whole biting surface.
Yeah.
And usually see a little brown line around that filling. What that is bacteria that's leaching under the restoration due to the expansion and contraction of the materials.
Yeah, so what do you think about around that? Expansion, contraction, material versus tooth. What do you think about, but the patient's not thinking about this, right? So what do you think about around that?
So the less tooth structure that's left, the more contraction and expansion you're going to get.
Right, so the more filling material.
The larger the filling material, the more expansion and contraction you're going to get, and those margins around the filling are more likely to leak, and bacteria will enter them. Again, it's obvious, like I said, when the patient comes in a recall, you can see a little brown stain developing around the margin, as opposed to a porcelain restoration, which is going to better fit the tooth. It's done in 2 stages, so the patient leaves with a temporary or provisional restoration, and it's made outside in the laboratory, so it's more of a precise fit. It's done under a microscope. And the material, the lithium disilicate, the porcelain, is not going to have the same expansion and contraction as the plastic composite filling is going to have.
Right, it's more like tooth surface.
Similar tooth structure, and that's why we used to use gold a lot in the past.
Yeah.
Gold is the most biocompatible to tooth structure. It's soft, it's kinder on the bite. So it's a healthy restoration. It's going to last longer in the patient's mouth.
When you do a composite restoration, you're competing with some other things also versus when you're putting an inlay or onlay in. Right? The actual technique of it, you're dealing with saliva patient, the light, the curing, the depth of it, the depth of the material, how it's shrinking. You're dealing with a bunch of compounding issues that I think about, and you and I talk about when a patient wants us to do or is worried about doing like a crown because of things they've heard, things they've thought about that. So, what do you talk with patients about longevity and how long these restorations last comparatively, especially as they get larger? I guess there's an issue.
Yeah. A lot of times, like you said, patients heard bad things about crowns. I do a crown, I'm going to need a root canal.
Yeah.
And composite is still a great choice on a small restoration. I find finances sometimes come into play. The patient just doesn't want to spend the amount of money, but if you look at the course of their life, how many times you may have to change that plastic filling, you'd be better off doing the ceramic onlay, inlay, crown.
From a pure financial decision, right?
Yeah.
Treatment time and financial decision over the course of a tooth's life is probably cheaper if you do something.
You know, if it's the first time the tooth has a restoration and it's not a tremendous filling, you try to stay conservative and do a plastic filling, a composite-based filling.
Could you do an inlay in ceramic over composite?
You could do an inlay on an occlusal. You could just do a small porcelain filling with a little hole in the tooth. And it's going to last, nothing lasts forever, but the patient's going to get many, many years out of it.
Yeah, I think with composites that they're typically under a decade solution, right?
Correct. Correct.
3 to 7 years.
Yeah, there's some smaller ones will last longer.
Smaller ones.
You know, once you break through the wall of the tooth and the decay goes through 2 or 3 surfaces of the tooth, that's when the tooth is weaker. That's when you get more expansion and contraction, and you're better off with a porcelain restoration that's going to better protect the tooth. Also, let's talk about protecting the tooth. Also, right? You see a lot of these big plastic fillings on the biting surface, and just a thin shell of tooth structure on the outside. So every time the patient bites on that plastic filling, it's acting like a wedge, and the walls of the teeth are expanding. And that's where an onlay will cover the full occlusal surface, wrap the cusps of the teeth, right? The cusps of the teeth are the part of the tooth that functions when we bite. So by better protecting them, less chance of the restoration wearing.
You know, I think about this a lot, that for most of the time in dentistry, we didn't have onlays available unless they were gold. So I think a lot of the thoughts around the inferiorness of larger restorations come away from it was a filling or a full PFM crown, porcelain and gold crown had to have a certain preparation to it to last. And so we're in a era of dentistry now that we have these intermediate solutions that might sound or feel like a crown to a patient, but they are truly more conservative, more protective in the short term and long term, right?
So what you're referring to,
these onlays
like
that you
an
do,
onlay, you could be more conservative with the preparation.
You come over and show me these onlay preparations almost every day that you're doing on a patient, that you're preserving a lot of tooth, but you're kind of shaping it in the necessary affected areas of the decay, and like, check out this preparation. It was preserving most of the tooth, and this inlay or onlay is going to be something that normally some dentists would do fillings, but it doesn't warrant
Others
a
would
crown.
do crowns. Yeah.
But we're able to do this intermediate solution that feels like a crown from the workflow of it, right? So what's the workflow of an inlay, onlay, or crown? Explain it to a patient. I have patients who have crowns who still don't remember what the workflow was.
Oh, they don't know the difference from it.
Right, so what's the first appointment or second appointment of an indirect restoration, as we call it?
Right.
Take it through, like, what happened.
You're starting the same way as you would with a composite restoration, or say a tooth with just a small cavity. The first procedure is removing the decay. You're removing the old restoration if there's one in place. If we're doing an onlay preparation, we are then making sure our walls are parallel, everything is smooth, and we're taking an impression, because this restoration is going to be made in the lab.
So you're shaping the tooth, taking an impression.
And the patient is leaving with a provisional. So we have to make it temporary. The temporary is going to mimic the final restoration. And the patient is usually brought back within a week or two, and the final restoration is bonded in place.
Okay, so it's 2 steps.
So it's 2 steps compared to one on a film.
Right now in our world, it's 2 appointments.
Basically.
In our world. There are some people who make restorations in 1 appointment, made of inlays, onlays, or crowns.
So let's talk about that.
Yeah, with the device in their office. It's still about, I think it's less than a third of dentists, if not less, that are doing that.
In their own office.
Same day restorations.
Right. So
How many same day restorations do you want in your mouth?
No. So what Dr. Raimondi referred to same-day restoration. So a composite filling is a same-day restoration, but it's plastic. It's placed in the tooth mechanically. It's cured.
Different.
It's polished. Yeah. On an onlay, now we're doing a lot of our dentistry digitally. So we could digitally scan with a camera that's taking 40,000 images per second, and we can generate a model from that. Some offices have a little desktop milling machine and are milling these onlay restorations in the office.
Real time.
And bonding them in the same day. We prefer doing it with the lab.
Yeah, why do you prefer that? I have my reasons.
The desktop milling units that a lot of these are using are maybe 2 or 3 point axes, and the ones that are using the lab are larger commercial machines, so they're milling these restorations a lot more accurate. Then the restoration could be stained and glazed properly. So as opposed to just milling it in your office, placing it in the mouth, and then polishing it in the mouth.
All right, so what's happening with the milling is there's a block of ceramic that is partially cooked, so it's not completely hard. The machine mills it to fit. Then you try it in, make any adjustments, and then you finish cooking in the oven real time in the patient's mouth. This can be great in the right hands, but I don't think the technology has come along to remove the technique sensitivity of it. I have some friends around the country that do this exceptionally. But that's the minority of people, either really technical individuals that love doing that and spend a lot of time. I think on average, I hate to say, but the average dentist who's doing this, it's part of a solution to get things done quicker, not better.
Correct.
Where we're pressing ceramic instead of milling ceramic, right? There's a
stronger.
Separate way of executing a restoration. So how do we?
If you had full lab support in your lab, the one-day solution has a little bit more of an advantage.
Yeah, we have some friends
if
that
you
do
have
that
a lab
also,
support
right, that have technicians
that
in
will
their
do that
office
for you.
that help along that process.
Where there's other offices that the dentist is doing the milling machine, they're taking it out, they're glazing it and staining it themselves.
And they could be great at doing it if they choose to.
Could be. It's a lot of work.
You mentioned the machines that are
So you get back
that are table side or chair
desktop,
top, desktop, whatever they call it. There's a few drills in there, and so they've engineered that the thing you're milling for the tooth has to fit the tooth, but the thing you're milling for the tooth has to be able to be milled by that size drill. So the engineers have figured out a way that when you scan a tooth the way you and I shape it, and then it designs the outer portion of the tooth restoration, the computer understands how to mill the inside of that restoration to fit the burr, not exactly to fit the tooth.
Right.
So you and I'd have to shape the tooth to accommodate the machine.
the drilling capacity of the
Where
machine.
there's a way to do this, where if you're making it a different workflow, that you can design the restoration to fit the tooth without accommodating the solution to technology.
Right. So would you say
that
that
may
these
make it-
machines are more accurate, probably milling a crown than they would be an inlay, which is more of an intricate fit?
Yeah, I'm not sure about that. I guess it just depends on the shape of your preparation versus not.
And there's not one answer for all. We do a lot of quadrant dentistry. What that means is, say, 3 restorations on one side of the mouth, and they're not all 3 crowns, right? One could be a small composite filling, one could be an onlay. If you look what they're teaching in dental schools now, it's all conservative dentistry, trying to conserve as much tooth structure as possible. Like you said in the past, it was either a filling or a crown.
Or a metal to porcelain crown.
And they would take a completely good healthy tooth that had a little bit of decay, might have been too big for a composite, and they would file the whole tooth down for a crown.
Right, the thought process was extension for prevention. Remember that?
Yep,
Right.
yeah,
Extension for prevention. All right. Something else I want to say.
What
about
else we got?
dentistry?
All right, Rob's going to dive into some water right now. I'm going to have a drink of water.
While you do that, yeah. We can also follow up on a couple questions around water that we received. We talked about our daily routines, our morning routines last time, about how to hydrate with electrolyte tablets and such. And so a few more questions around that. Do we have a specific type of water that we like? Things to avoid? How much water should I drink? So,
What do you like to drink?
well, I think we could talk about the pH of water, because there's 3 types of water. There's acidic water, there's neutral water, and there's alkaline water. And I think about that, the influence in your mouth locally, and then also systemically what happens, because there's a couple things to think about. Acidic water is the worst. So, for example, a cup of coffee here has a lot of water in it. It's acidic. Many bottled waters are acidic. You should know the pH of what you're drinking, because this is going to contribute to the bacteria in your mouth that can cause disease. And then also, this is less absorbable than neutral or alkaline water. So the problem with drinking things that are acidic, locally bacteria in your mouth, and then also systemically, it's not as absorbable as other waters. if this is decaf coffee, because it's caffeine, but if there was caffeine in it, that's also dehydrating. So you're drinking acidic, dehydrating water,
So double
which is
negative.
which has some problems about it. So we can head over to something like this. This is an alkaline water.
What's the
right?
pH of that?
I'm not sure the exact this says plus 9.5. I don't know exactly where it is in the score. They get it's that or above.
Yeah.
And so it's the inverse of acidic water, and alkaline water is the most absorbable type. I like it in your mouth because it combats the bacteria that cause disease, and it also, believe it or not, is more absorbable in your stomach, in your gut. Not your stomach, but in your GI tract. Your stomach's not absorbing water that so much. Because of the nature of it, it can pass the membranes better than acidic or neutral water. It's not making your body alkaline. It's not deacidifying your body, but it is more absorbent. So I like to start with a neutral or alkaline water for hydration purposes and for the health of my mouth. I find that it's maybe makes you more hydrated.
So are you drinking different waters throughout the day?
I mean, you and I drink filtered water a lot during the day here at the office because I'll finish that bottle and I'll refill that bottle. Right, it's a non-plastic bottle. Who knows if that's good or not?
And what would you say the pH or alkalinity is of New York City tap water?
I think it's like 7.2 and above, right? 7.2, generally speaking. I know when I've tested my own, like in my apartment and such. So the first note is you want to think about the quality of the water you're drinking, and how it affects your mouth and how it affects your overall body. And not to misunderstand that it's helping to balance the acid properties of your overall body. But your body cannot absorb acidic things. It can't absorb it. So your body actually has to neutralize it before it can absorb it. And the other thing I think we were thinking about, I was talking with a few patients about following from our talk last time, was the quantity of water. So how much, because you and I are saying how we drink a lot of water in the morning. And so take your body weight, divide it in half. That's about how many ounces of water you should drink. And you should front load your day with that water. Has to do with your kidney function and how much your kidney actually starts to absorb water and function, because when you go to sleep at night, your kidney slows down its actual function.
That's a lot of water.
So
you think that's
you want
feasible?
I try to divide it an
So if
hour.
you're 180 pounds, right?
Yeah.
So
You want to drink
90 ounces of water a day?
And you want to do that in the first 2/3 of your day,
Yeah.
your waking hours. So you break it up. So you say if you're doing 90 ounces, a good goal is 8 to 10 ounces kind of every hour throughout the first portion of your day till you hit 90. So if I can drink 80 to 100 ounces in the first 8 to 11 hours I'm awake, that's going to be more hydrating. And I'm trying to slowly drink it.
Yeah.
The way you drink it matters a little bit too, right? So if you chug a bottle of water, that's less hydrating. Or if you drink that 16,
Just sip it.
if you drink a typical bottle of water, 16.9 ounces. If you drink
Drink it over
the course of 2 hours versus chugging in 10 minutes, the 2 hour slower, tighter of you drinking that will be more absorbent and more hydrating than if you do a big full flush. And then
basically you're drinking all day then, right? If you're doing 16 hours,
Yeah.
four times a day, it's
Try not to
64 ounces. You're still not there.
Yeah,
yet.
I'm trying to drink in the first 2/3 of the day and staying away from drinking a lot of hydration near bed. I don't want to wake up and have to use the bathroom. You and I, we talked about the electrolytes last time. We like to put some sodium or sodium, potassium, magnesium in our water.
So compare that to like a seltzer water.
Yeah, seltzer's the worst thing.
It's the worst thing.
Right, because seltzer's terrible for a hydration standpoint, although I enjoy drinking it because of the taste
It's
and the
okay.
mouthfeel.
It's okay in moderation.
Like anything, but it's less hydrating because of its pH, of its acidity, and just the carbonation of it doesn't actually do anything better for your body. So if you drank equal amounts of carbonated water and tap water, you're going to have a different effect on your body. It's more, you're going to absorb more of the hydration from the neutral water versus the sparkling. So I drink still water at restaurants, although I love sparkling, but I don't do it. And we have Christy here. Who's over there, Mark?
Hi, Christy.
Hi.
Good morning.
Good morning.
You have any questions for us?
Anything
your
for patients?
patients?
Yes.
Yeah. All right, so staining along the gum line of your teeth. So this is a extremely common thing people talk to us about. And what are they looking at? Is it the actual tooth or
Specific areas?
really the
It's
root?
just everywhere. And you
Yeah.
can see it in the front.
Yeah, a lot of staining. So one thing that people misunderstand is that when they get a small amount of recession, the end of the enamel and the starting of the root starts to show, and that's a different color than the enamel of your tooth.
Right, and that area of the tooth is also more porous.
More
We're
porous.
talking about cementum, root surface,
Right,
so the
cementum,
bacteria
dentum,
sticks to
yeah.
that more. Kind of piggybacks with the hydration, right? If you have a drier mouth,
Yeah.
the food's sticking to those areas more readily.
Yeah, it's a porous. It's where the ligament of the tooth and the soft tissue of the tooth anchored into. So by nature, physiologically, it had to be more porous. And like you said, it's a different color. So people don't like the way it looks, and a lot of patients always say to us, "What can I do about this? Can you put a little something? Can you
That was
paint?
my next question.
Can you paint something on
Yeah.
there?"
Can
How many times?
can you
how
just
many
paint the
times-
teeth?
How many times have you even asked that in your career?
Yeah.
Hundreds of
Can we
times.
just paint the teeth to
Just
whiten
just
them?
paint it.
Yeah.
Just paint it. Like my house. I painted my house.
Somebody's got to invent that.
Yeah, somebody, yeah. To the paint. I can't tell you how many times I've said to a
Yeah,
patient.
yeah.
I remember one patient said, no, you guys are really smart here. You have to come up with
You gotta
something.
figure it
I
out.
go, I figured it out. It's called a veneer. I mean,
You
I
can't
don't
do a veneer on the teeth. You got to figure it
I
out.
don't, no, I'm not doing veneer. Something different.
You know,
I haven't figured
patients
it out
say,
yet.
why can't you put a little bonding on there? And that goes back to what we were speaking about with composites. A little bonding in that little area down by the gum line,
Yeah.
you're not getting a great bond.
You don't want
More
to
expansion,
over
contraction,
contour it. It has to fit within the biological shape of the tooth.
and they don't last very long.
Yeah. Well, I think that
it's
as
about
we
better
age,
oral
yeah.
hygiene, right?
Better
A
oral
lot of
hygiene.
times patients are saying they're just missing those areas, brushing.
Right. I think doing your hygiene
more frequently.
in front of a mirror and looking at how you're cleaning those surfaces. And of course, those people who stain a lot, because there are patients who stain a lot because of the tannins they ingest or just the nature of their teeth, they can uptick how many hygiene appointments they're getting in a year.
And their diet, do whatever.
And they work with the right hygienist to not overdo it, right?
Yeah.
So if it's not so much tartar buildup, you can have a more sensitive hygiene appointment as stain cleaning instead of it's the same routine just every time that some hygienists will do. Not like you, Christy. What else? What
What
else you
else?
got?
Here's another one.
Is there what is a cosmetic dentist
Let's
versus
talk about
a
the-
general dentist versus a
Yeah.
prosthodontist?
So let's talk about their recognized specialties in dentistry. We're prosthodontists.
Can we call ourselves cosmetic dentists? I guess we could, right?
I guess so. Right?
Anyone could.
It's really not a recognized It's
Specialty.
not a specialty.
Yeah.
You could take a weekend course on doing different
It's a
composites and all.
self-appointed title.
Yeah.
I call myself a cosmetic dentist, so therefore I am a cosmetic dentist,
Yeah.
right?
Yeah.
They call themselves, and I think it's more of a marketing thing. Of course, they could choose their practice to focus more on cosmetics. That's fine. That doesn't mean that there's a cosmetic dentist is different than any other dentist.
It's not
Right,
a recognized
right,
specialty.
right.
It's just something a title that you give to yourself.
You give to yourself, where a prosthodontist is a recognized specialty.
Right. You could take all
We
the
feel
courses
good-
in the
we feel
world.
good
You're
about
not going to
ourselves.
become a cosmetic dentist. It's
Right,
just something
right.
you
There's no-
choose to call yourself.
Yeah, there's no formal training.
Correct.
Academic
There's no
formal training.
advanced education.
There are pathways for, like the Academy of General Dentistry has a fellow and has different layers of education. The American Academy of Cosmetic Dentistry also have
Some great-
have great tiers. They have different levels, fellows of these academies. So that's a different thing.
Yeah, there's
they
some
actually have to.
Great societies, great meetings, and they're
right.
teaching better techniques to get better aesthetic
Yeah,
results.
those dentists they're not prosthodontists, but they are some fantastic general dentists that have committed themselves to education.
More education.
So I would ask people to look for these dentists that have focused more on their education, becoming a fellow of a accredited organization like the Academy of General Dentistry and the American Academy of Cosmetic Dentistry have some education tracks you can find on their website. And there's some really great dentists that are very, very intentional and good at what they do when it comes to cosmetics. But just by putting on your card, on your website, on your Instagram that you're a cosmetic dentist, you just decided to call yourself that. And that's okay.
Correct.
But just go deep.
Right.
Dive
Is there any
deeper
other
into it.
profession that does that you can compare it to? Right.
That's a great question.
It's a good question.
That's a
right?
great question. Now you gotta look. We gotta look that up to see if there's and
Yeah.
what other.
No, like looking in medical, a plastic surgeon.
I guess there's like functional medicine doctors versus there's a concierge the thing, but I don't know if it's an actual
Yeah.
where the public
I guess
it's
another one would
misleading
be
to the
a.
public. What? I don't even know.
No, I can't think. of
I don't
one.
even know. It's a great question. What else you got, Chris? You know, I found that when I have the right floss for me, I'm much better at doing it. When I like the time I'll run out of that floss and I'll have a different floss that I don't love, it becomes more of an act of labor. Where when I have such a, when I have the flosses I love. But I really mean that though. When I have the flosses that I
When
like
you have
to
your
floss
cocoa
with-
floss, you're good.
No, I don't like cocoa floss. For my mouth, cocoa floss is an amazing floss, but it's too thick for
Yeah.
my posterior.
Yeah.
So I have to use a thinner floss posteriorly for me.
Tighter
What do you
contacts.
use daily?
I like an unwaxed floss.
For which brand? Which exact floss do you like?
I'll still use the cocoa floss, but Oral-B. I'm not as particular as you are with the floss.
I'm very particular. I am very particular with the floss.
But I do floss every day. If I don't, I notice when I go back and floss, I get a little bleeding here and there. All right?
Yeah, I'm at a point where if I do, I rarely miss flossing. But if I do, like when I wake up in the morning, I can sense it, feel it. It's just different, and I'll do it first thing. Do you floss every day?
I floss at work more
Yeah.
than I
Yeah.
floss at home.
Yeah, well, you have two
Interesting.
young kids. Yeah.
So I'm
But
the same
I'll
way.
water pick in between.
I'll floss at
You
I'm
do.
lunch.
lazy with the floss, I'll water.
Yeah, there's a supplement. You clean between your
Yes,
teeth, which is
yes.
what we talk about.
Yeah, but see, I'll floss
Yeah.
at lunch or at bedtime. I don't floss in the morning.
I floss
remove-
at night. At night.
Yeah,
routinely.
okay. I thought you did in the morning.
No, if I miss it
Gotcha,
at night,
gotcha. Yeah, you
and I'll
want-
feel.
if you're going to floss once a
Feel
day,
it.
you want to do it at the end of the day.
Yeah.
Right.
All right.
Nothing wrong with flossing twice a day.
Well, you do it the right way. Nothing's wrong with it. All right.
You ready to go to work?
I think we have to go to work. We
Let's
have
go.
patients in 3
All
minutes.
right.
All right. Be well, everyone.
Thank you.
Yeah.